Thanks for being here with me this afternoon. My name is Katie Gaughan. I'm the programs manager for a Chicago-based nonprofit called the Danny Did Foundation. We're excited to be back this year. We've been partners of the ADDL for 12 years, which is really exciting. So we're super happy to be with you. Just a quick overview of what our presentation is going to talk about. I'm going to start by sharing the story of Danny Stanton, which includes the discussion of his cause of death, which was sudden unexpected death in epilepsy, or SUDEP. We're also going to touch on technology in the epilepsy space and its utility to parents and patients and caregivers. We'll certainly save time at the end for questions, so I'm happy to chat through any of that after. And Danny Did has a table if you haven't found us yet, so we can always continue our conversation there as well. So first, let me introduce you to Danny. Danny was an athletic, affectionate, smart kiddo. He enjoyed doing everything with his three siblings, Mary Grace, John, and Tommy. I grew up in the house next door to Danny and his family, so I am one of the lucky ones who got to know him. Danny and his siblings were always in and out of our house, visiting my mom's snack drawer and then heading back out to play. So they quickly became like family. Danny had his first seizure at the age of 2. His parents witnessed just 4 more seizures over the next 2 years, but always wondered if they were missing anything during sleep. He had no other medical complications. Just a few months before Danny's 5th birthday, he visited his neurologist on a Tuesday. They got good news. Everything was on a good path. They adjusted his meds a little bit to account for some weight gain and growth, but ultimately they were told they're on a good path. 4 days later, on Saturday morning, Danny was found lifeless in his bottom bunk. The first time that his parents learned the term SUDEP was on Danny's death certificate. Danny's parents, Mike and Mary Ann, started the Danny Did Foundation to fill those gaps in education and communication that they experienced during the treatment of Danny. The name of our organization comes from the last line of Danny's obituary that was written by his dad that read, "Please go and enjoy your life, Danny did." Despite our tragic origins, the spirit and the joy of Danny's life motivates our work to help other families. So Danny's new place in the world. At Danny Did, we have 2 main points of focus. First, increase public awareness about epilepsy and the risks associated with it, and in particular, the risks of SUDEP. We advocate for honest and open dialogue between doctors and parents. As we all know, caregivers can and do digest difficult information all the time. It's part of our job as caretakers to do so, to consume information and then use that to shape the best possible treatment plan for our loved ones. And then our second point of focus at Danny Did is to increase awareness and access to devices and technology that alert to a seizure. To give you a visual representation of our work, I'm going to show you a short video here next. You guys hear?
Always full of energy.
He was about 3.5 when he was supposed to be there. In the days and weeks following, he ended up having many more seizures. Realized that it was going to be long enough for him to figure out how to manage it. We started having him sleep in bed with us because he was also having seizures throughout the night too. We were not sleeping, so anxious, so worried that my brain was just like worst case scenario, like on overdrive all the time. I really thought for a while like life is never going to be the same again. Those were like some of our darkest times, and how Danny Did come in and turn that around for us was life-changing.
Danny Stanton was my first friend, and he was my neighbor, and it was really just some of my first childhood memories were hanging out with him. Danny was really just like a friend to everybody. One of the most impactful things about Danny Did and their growth in the last 15 years is that someone that was one of my first friends has become a friend to so many people through his legacy and impact. what happened to Danny should never happen to anybody else. It's an avoidable situation. If we continue to spread the news about SUDEP and continue to help families through devices.
It was like such a relief to one phone call and then all these people were helping us.
Knowing that that device was readily available for us at no cost, because Danny was able to provide it for us, was a relief. The device letting us know that we stabilized the medicine, we can keep everything as is, and he can go be a kid was great.
It's like just so beautiful how many families that they've touched, you know, not just in the Chicago area now, but across the whole country, across the world.
Hola, mi nombre es Elizabeth Saucedo. Yo vivo en México con mi hijo Daniel, que está por cumplir 28 años. Él vive con el síndrome de Lennox-Gastaut desde que tenía 2 años, entonces su epilepsia es de difícil control.
My name's Cody Stevens. I live in Cambridge, Maryland, which is about an hour and a half or so from Baltimore. My son's name is Luke.
I was diagnosed at 23, so I've, been dealing with this for 15 years. I thought, I could do this alone. I thought I can, it's better not to tell anyone and just deal with it.
At Luke's worst, he was having between 30 and 40 seizures an hour. We reached out to Danny did, and they responded right back.
I couldn't believe at the beginning that I will be able to receive a help from the Danny Did Foundation. So I'm really grateful for the support. It's a life change.
To give Luke this independence, it's been a game changer for all 3 of us. There's a lot more momentum, there's a lot more positivity. We're encouraged to move forward at this point from where we are.
How Danny did empower me is like, now I want to own this. What Danny Did Foundation does for me and my family is beyond words.
If I could talk to Danny, I would want to tell him how much of a difference he's made and how many lives he's impacted for the better.
We are so thankful to everyone that supports Danny Did, no matter how big or how small. Thank you. Thank you so much.
Hopefully you guys could hear that. If not, it's on our website if you want to go back and watch it, but hopefully you could hear most of the messages. So before little Danny died, his parents had never heard the term SUDEP. It was never a risk that had been raised with them by Danny's neurologist. A death is referred to as SUDEP when a seemingly healthy person with epilepsy dies unexpectedly, and there's no clear reason for death that can be determined. In most cases, an autopsy is required to rule out other causes of death. The most common criteria used to determine whether a death is due to SUDEP are the person has epilepsy, the person dies unexpectedly while in a reasonable state of health, the death occurs suddenly and during normal activity, typically often during sleep. An obvious medical cause of death could not be determined at autopsy, and the death was not a result of status epilepticus or prolonged seizure clusters. In most cases, SUDEP, the incident is not witnessed and the patient is found dead in their bed in the morning by their family, and that was the case with Danny. The precise reason regarding what causes a case of SUDEP are still being researched. That's one of the most frustrating pieces and aspects about SUDEP. We don't know exactly why it's happening, but there are a few main theories. One is called cerebral shutdown. When the brain is shut off just following a seizure, breath may be suppressed, and the lack of respiration may be a primary cause. There's a new published paper in the Journal of Clinical Investigation from the University of Iowa lab that's exploring this aspect of SUDEP. The second is cardiac abnormalities. A seizure may cause a dangerous rhythm and even heart failure. It's also possible that SUDEP may be a result from more than one cause, and other causes may also impact it as well, and it might be slightly different for each person. The most recent research suggests that SUDEP occurs in 1 in 1,000 people with epilepsy. That applies to both adults and children. For people whose seizures are uncontrolled, however, that rate does increase to 1 in 150 people. So seizure control, as we all know, is critical. Uncontrolled seizures and regular tonic-clonic seizures at night present 2 of the greatest risk factors for SUDEP. People who are in either or both of those categories, either a high volume of seizures and or convulsive seizures during sleep, are at the highest risk. Danny fell into the latter category. Other risk factors being looked at include epilepsy beginning at an early age, having epilepsy for a long period of time, not taking medication regularly or as prescribed, and then, of course, other lifestyle choices, including drinking alcohol, could contribute to seizure activity. At the Danny Did Foundation, we can and do disclose the risk of SUDEP directly to caregivers. We always maintain that this information is best delivered by a patient's doctor. It really does build trust. In 2017, the American Academy of Neurology and American Epilepsy Society passed the first ever practice guidelines on SUDEP, which essentially said that all patients should be counseled about this risk. This was significant because many providers have historically leaned on the idea that only the highest risk patients and their caregivers should be counseled. We encourage you as patients and as caregivers to be a part of this change by initiating the conversation about SUDEP. This topic is important that Danny Did joined another advocacy organization in distributing a Duke University study and survey that was given to caregivers in the epilepsy community to learn about how parents prefer to learn about the risks of SUDEP. The overarching takeaway was that caregivers want to receive the information about SUDEP from their healthcare provider, but they typically hear about it elsewhere. On the other side, you can see that the disparity between what a caregiver desires versus the current standard of care. In an open-ended response from the study, which was published in last year, in the Annals of Child Neurology Society, caregivers highlighted the value of learning about SUDEP from a healthcare provider and the importance of pairing SUDEP risk disclosure with discussion of how to reduce those risks, and the need for education resources and peer support. These findings highlight the urgent need for intervention to improve and support the SUDEP risk communication. There is no 100% prevention tactic from SUDEP, but we do believe there are steps we can promote for patients and families to minimize their risks. It all starts with communication. Communication about the risks with their provider. You can kind of see how these different ways to minimize the risk. Advocate for increased awareness by the public. Maximize seizure control via strict treatment adherence. Regular physical activity and lifestyle habits that reduce risk in seizure activity. Regular doctor visits if convulsive seizures are not completely controlled. Ideally to a specialist, which within epilepsy is called an epileptologist. Ensure that family members and caretakers have the knowledge of seizure first aid as well as your seizure action plan. Advocate for research into better understanding for the causes of SUDEP. There's a new toolkit resource called preventingepilepsydeaths.com that we encourage you to review. It's a toolkit for both clinicians and patients to learn about reducing the risks. Consider the use of alternative resources such as a monitoring device that detects certain seizures and can alert caretakers and enable early intervention. The last piece there is a main focus of ours at Danny Did. Technology within the epilepsy space is fast growing. We consider devices and technology as a complement to medication, surgery, diet, all as part of a patient's treatment plan. I'll explain more about the specifics of seizure alerting devices in a minute, but let's first discuss why we feel patients and clinicians can benefit from using them. We view devices as another tool in a parent or caregiver's toolkit. A device never replaces a parent's intuition or their vigilance, but a monitoring and alerting system can be one piece of the puzzle, lending backup that you will be notified if a seizure takes place. Monitoring of seizure activities within a hospital is so important. A patient would never be left alone or unmonitored in that space. When a patient leaves the hospital, however, what then? We feel that monitoring at home is just as important. We feel strongly about the simple concept of early intervention. If you are present, you can take action, and you have a chance. Improved seizure tracking for a person with epilepsy. Often epilepsy can come with memory issues. Some people say, I'm really not sure that I had a seizure last night or yesterday. Improved seizure tracking for caregivers, who is responsible for that patient. Adding safety for a person with epilepsy, knowing that someone is coming to their aid can really be a game changer for that person. Which then leads to reduction in anxiety, and wearing a device can increase independence of a patient, allowing a child to go to the friend's house, or go to a park, allowing adults to go to work, or the grocery store. Simple things like that, but allowing for independence. And then increased peace of mind for a caregiver. I will receive an alert and can be there for my loved one. No one should be alone during a seizure. The management and treatment of epilepsy are mainly guided by assessment and seizure recurrence and frequency. But self-reporting and patient recall is often unreliable. So these can be a real benefit to clinicians. Clinicians like the devices that they engage patients in their own care, in their own sharing of data, having healthy and honest discussions. They like that devices prompt timely intervention that reduce risks. They can provide more accurate data, the frequency of seizures, and again, that less reliance on patient recall. And then better data can trigger more effective evaluation and optimization of medication and treatment plans. And then often these devices are collecting so much data that hopefully in the long term, many of these devices may be providing reliable biomarkers for SUDEP in identifying highest risk patients. So let's get into talking about devices and how to select one. It's not easy to stay current on all the technology options. The marketplace and the pipeline are always growing, which is such a wonderful thing. But this is an area where Danny Did can be a resource to you. Our role is to not recommend or to endorse a specific product, but simply let parents know what their options are. Before picking a specific device, it's important to go through a checklist of practical, common sense considerations. 1, determine the best method of detecting your seizure type. That's so important. When considering an alerting system, an obvious first step is to look at whether the device can detect the seizure type that you want to monitor. Different seizure types can be detected by different methods. 2, determine your goal for the device. Define your motive for monitoring a seizure. Helps to ensure that selecting devices meets that goal. 2 examples are, 1, do you want someone else notified that a seizure is occurring? And or would you like to also track your seizure occurrences and have the time and the date and the duration? 3, consider the comfort and relevance of the device. No device will be effective if the user is not going to wear it properly, or it can't be set up, or if it's uncomfortable for a kiddo to use all day long or wear during sleep. Determine the ease of use and setup. You don't want to add a complication. So how easy is it to bring it into your home and set it up? And then of course, determine the cost of the device. Monitoring devices can have multiple costs. So what is the cost to purchase the device initially? Is there a monthly or annual fee that will go along with it? Are there setup or maintenance costs for the device, or any other technology needs that you need to go with and complement that device? And then is the device covered by insurance or any medical expenses? Unfortunately, at this time, most of these devices are not covered by insurance. And I'll tell you more about how we can work to address that resulting access gap. So within the epilepsy space, there is a range of device types. Some of them are implanted and involve surgery, for example, the VNS and the RNS that some of you might be familiar with. These types of device treatments are typically reserved for patients with refractory or uncontrolled epilepsy. Invasive procedures, especially for kids, can be a hard decision for parents to make. Because of that, many parents and caregivers may start or are more inclined to try a non-invasive solution first. It's likely that everyone in this room knows the vulnerability of seizures during sleep. There are mattress sensors and video-based monitoring for nocturnal use. For people facing seizures, nighttime can be an extremely scary time, and an alerting device can provide a layer of support that families may be desiring or need. For individuals that have seizures at any time of day, there are wearable options. There are wristwatch-based sensors that will attach to a mobile app that are compatible with both Apple and Android products. These devices allow an individual to, again, maintain some of that independence, like I said, such as go to school, go to work, get to play with friends, get in the comfort knowing that someone will be alerted in the instance of a seizure. Early intervention is so important during a seizure. Depending on each individual, intervention may look different, but no one should ever be alone. When someone's alerted to a seizure, they can take the necessary steps to keep their loved one safe, including providing a rescue medication. These devices complement a patient's medication and treatment plan. Danny works with families and not companies. We do not sell any of these devices. We don't endorse one or the other. We just want you to know what's available and what's out there for you to keep your loved one safe. So I'm just going to briefly go through some of the devices that are available to you. Again, I'm happy to answer questions at the end or over at our table, so feel free to stop me. This list is not exhaustive. There's more in development, and there's really wonderfully smart people always developing new technology, and we do our best to keep our finger on the pulse of what's happening. And then they will not include the implantation systems that I referred to, the VNS and the RNS. So the nocturnal monitoring systems that I had referred to a few seconds before are the MFit movement monitor and the SAMI, the sleep activity monitor. The MFit movement monitor is a super thin pad that goes under the person's mattress, and when it detects any sort of seizure activity, movement, then an audible alarm will sound in that person's room. And if you are across the hall or down the hall, you can hear it and get in there and intervene. Then the SAMI system is a camera-based monitor. It's similar to like a video baby monitor, if you can picture. There's a camera that would be mounted above where the person's sleeping. The parent or caregiver will have an iPad with them. Wherever they are in the house, you can take a live look in, you can take a peek at any point. There's audio. But once the system detects any sort of abnormal motion, and the manufacturer does say even small subtle motions, eye fluttering, lip smacking, small little subtle jerks. Once the SAMI notices that, an audible alarm will sound through that iPad that you have. You can get in there, intervene if you need to. Once the system is triggered, it will begin recording a video. And then those video recordings you're welcome to share with your doctor if you choose. They're all stored right there on that iPad. So wearable monitors. There's several different types. These here are the Inspire app. The Embrace Watch by Empatica, which they actually just updated, which is the Epi monitor. So there's a new model out right now, which is great. And then Seize Alarm. These work very similarly. Inspire works on both Apple and Android products. The Epi monitor actually comes with its own watch, so it's something that the company will send directly to you. And then Seize Alarm is an app that is compatible with Apple products. And what these watches do is they monitor for seizure activity. So movement, the convulsive shaking, jerking of a seizure would send a signal to the user's phone. So it's important to keep in mind that the user has to have their own device. Once that signal is sent, that phone sends an alert to up to 3 people of your choosing. And those alerts come through in the form of a text and a phone call. And then once you get them, you can get there, intervene, or you know your child's at school, do you have to call the nurse? Are they at work? Some of these products also have GPS location. So if someone takes the bus or walks to work or something like that, you would get a little GPS location to know where they are and get to them. You may be familiar with a pulse oximeter. Portable pulse oximeter or non-invasive medical device. It's typically attached to a person's fingertip or a little kiddo's toe. It's monitoring for heart rate and blood oxygenation percentage. Both are vital statistics that affect a person while they're experiencing a seizure. Now these devices, they do require a prescription, and you would go through what's called a DME, or durable medical device company, and you would go to them and you would get your pulse ox through there. But that's something that somebody could wear continuously. If somebody's in a stroller or a wagon, you could have it with you. And then also parents use them a lot at night as well to monitor for seizures for individuals who may not have movement but are seeing changes in heart rate before, during, or after a seizure, and then of course changes in respiratory rate as well. Okay, so let's talk a little bit about limitations. There's always a need for further development of products in the device market. However, the process to get a device developed and covered by insurance is not a smooth path yet for devices, as there are still many of them in their early stages. The FDA requires high-quality validation studies, clinical studies on different medications, therapies, medical devices is always kind of moving forward. This can be a long and expensive process, but one that is essential in helping the future of devices. One day you may be asked to be a part of a clinical study for a new product, and we definitely encourage you to do so. It just really helps the space and shows that these devices are needed. Studies on the effectiveness of the device to reduce false alarms and to lead to product improvement is also crucial. Most doctors are not really comfortable with referring a patient for a device that's not FDA approved. So again, just kind of lends back to why that piece is so important. And Medicaid and private companies will, often won't cover any of the costs without an FDA approval. So devices that are used in a hospital setting do not always work the same at home in that setting. So that can be a barrier. And so that's what parents are searching for, something similar to the monitoring that's happening in the hospital, but that they can have that same sense of safety and monitoring when they're at home. And then some product weaknesses that we feel need to be addressed. One, the use of one device that can detect a multitude of seizure types. For instance, some families are using a heart rate monitor, they're using a movement monitor, they're using a video camera. They have all these things set up in their child's room where we feel like hopefully one device can merge all those things together. The rate of false alarms needs to be reduced, or families will become obviously frustrated. They might even turn them off, kind of have alarm fatigue. And so they'll just set that piece aside. And then of course the battery life, Bluetooth strength, so you can be anywhere and still feel that the device is connected. So what's coming next? And what is new in the epilepsy space? Systems using indicators other than movement and detection. Patients and doctors are desiring more focus on respiratory and O2 saturation to determine a seizure. New apps and software that are being developed. An example is using an app diary that works with algorithms that are already in place to forecast the likelihood of your next seizure. Apps and portals that share data between doctor and patient between doctor visits. Seizure apps that share information with doctors to help during transitional periods. So recognizing side effects and report any increase or decrease to seizure activity to determine if the change in the treatment plan is necessary between a person's appointments. So that's something that people are kind of working on and making sure bridging that gap too. Did my med change work? Is this the right path for us? And of course, the pipeline, this is something that Danny Did is super interested in. As I mentioned before, we really try to make ourselves aware of what's upcoming. For instance, there are devices that are being designed to predict a seizure before it happens. There's a company in Israel working on this type of product. It's a headband for use at home using EEG leads. They're called NeuroHealth. And an innovator in Zambia is working on an earpiece that can detect seizure activity through EEG technology. It's called the Purple Glow app. We have conversations with companies all over the world. We're very excited about these possibilities and the interest in the field and the medical technology space. Danny Did is part of the pipeline contest called Shark Tank, where we get to hear from up-and-coming innovators present there. They get to divide up a cash prize to further their work into the next stages of development. We're also part of a product accelerator course and roundtable conference that furthers medical device development. And the ultimate device would, of course, be a non-invasive system that predicts a seizure and delivers an intervention to suppress it. So next, we'd like to discuss our seizure detection device program that awards families in need. As mentioned, the FDA and insurance coverage is not where we would like it to be. So Danny Did is here to sort of bridge that gap. And we ask doctors to refer patients to us to secure these devices. So many families come to Danny Did to find resources that will help with selecting a device system and questions that they can ask the manufacturer as well as their doctor, like we talked about a couple slides ago. Some of our conversations will end there with information, education. However, because most seizure detection devices are not covered by insurance and they can be very expensive, this is where Danny Did can be a resource to families. If finances are a barrier for a patient or caregiver, they can apply for grant funding to make their purchase. After a family has decided on a device that might work best for them and have submitted an application, I will reach out via email and we'll set up a scheduled time to talk. We do a short interview. And then and I help them kind of work through that process. And then if the grant is approved, we provide funding directly to the family to make their purchase. So the family gets to make their purchase, it's their device, they have the relationship with the company then, they have the warranty and all the things, it's truly theirs. And then of course we do our best to keep in touch with every family and continue to be a source of information and friendship. So please definitely come stop by the expo table and talk with myself and my colleague Callie, who's in the back, who also helps me with our grant program, because there's certainly a need, and so both of us do our best to reach everybody and talk to everybody. So come on, stop by, and we'll keep chatting about this program for you. DDF is a proud partner of Partners Against Mortality in Epilepsy. PAMI's mission is to convene, educate, and inspire all stakeholders, from the bereaved to those living with epilepsy, to healthcare professionals, advocates, clinical and basic scientists, and death investigators, to promote understanding and drive prevention of epilepsy-related mortality. PAMI offers webinars throughout the year and meets the first week of December this year for a full day of presentations, breakout segments, research posters that are covering different research being done in mortality studies. And then the afternoon before the day of education, families and advocate groups meet for the afternoon. The topics are often include bereavement sessions to learn more about advocating in memory of your lost loved one. And then of course, we invite you to get involved as Danny Did. We have really a wonderful, sweet family at our table currently who is a family ambassador. So we have family ambassadors kind of all over the US that will speak on behalf of Danny or go meet with families or just kind of be a source of information for their state or their location. So that's an option to you. And then if you're athletic and want to bike or run or swim or walk, whatever you do, feel free to reach out and learn about Team Danny Did. It's really an incredible group of people. We're currently recruiting for the next Chicago Marathon, which is next October. Ultimately, we really like to have fun, enjoy life like Danny did, and build events around any sort of theme. So if there's something that you're really wonderful at or love to do, we'd love to hear about it, and you'll get to do a little thing in your hometown if that's what you want to do. So let Danny did know how we can help you and be supportive. Lastly, we're here to help both families and clinicians, but also want to engage everyone interested in our mission, who share our feelings of hope and want to provide safety for those living with epilepsy. We're available if you have any follow-up questions from this presentation. Feel free again to stop by our table, and please remember to go enjoy your life. Danny did. Thank you guys so much. Are there any questions you wanted to ask or anything you wanted to talk about? Yeah.
I'm learning about, like you said, SUDEP. It's not something that we know enough about. But I was under the impression that if what caused SUDEP was maybe the person having a seizure during the night and then someone not being there,
Yep.
you know, to make sure that they were on their side and things like that. But it sounded like you could just have, without a seizure, your brain could just sort of stop functioning.
Yes. So SUDEP, like I said, they're looking at different biomarkers and different things that could potentially increase your risk. And so following a seizure, one of the theories is that your brain kind of resets. For some individuals, it's not turning on quick enough
After the seizure.
after a seizure, and so that's when we get that cerebral shutdown, that period of time where the brain's kind of resetting, and so the brain's not telling your body to breathe or your heart to beat. So yes, there are certainly factors, and safe sleep is so important. You know, they have pillows, anti-suffocation pillows and things like that, and that's all wonderful, important stuff to help mitigate these risks. But yes, it does seem through a lot of these studies that there's other pieces to the puzzle that could be a contributing factor. Yeah, that's a good question. Yeah.
Okay. First, thank you for bring my daughter and me to this event. Thank you so much. She has KCNA2. It comes with a lot of features: ataxia, hypotonia, spasticity, many other things. So how SUDEP can be ruled out when there are other causes that can lead in death?
That's a great question.
And it's also confusing for me that the first part say healthy person with epilepsy.
Right.
There are so many kinds of epilepsies that comes with many other things.
Yes.
Uh-huh.
Yeah, so great question. And so one of the factors that will lead to a SUDEP case is when a person with epilepsy in a relatively good state of health. So no other contributing factors. So just to use Danny as an example. Danny was a relatively healthy boy other than having seizures, other than having epilepsy. There were no other medical complications, no other true medical history going on. So when it's a case of SUDEP, they are seeing that it's due to a seizure in a relatively healthy person. So like you're saying, you have all these other things going on. What they would have to do is be able to rule out that it was nothing else other than that seizure, if that kind of makes sense. I know it's kind of complicated and hard to understand, but SUDEP, where if somebody passes away, unfortunately, and has kind of a longer list of medical complications and a long medical history, you'd have to rule out that it was not any of those other things. And sometimes people, if they pass and have complicated medical histories, it will be due to a complication following a seizure and not necessarily with the word SUDEP on it. Does that make sense? Yeah. It's good to meet you. Hopefully we'll get to talk more. We do have travel grants. So some of our sweet families that we got to send here are here. So it's so good to see you.
Thank you.
And that's a great question. It is complicated to truly understand, is it a case of SUDEP or a complication due to other things? Yeah, great. Yep.
Do you know if there's any devices out there that, for example, I got my son the watch,
Right.
the mattress pad, you know, the whole thing.
All the things,
But
yeah.
the watch in particular was sending me false alarms. Oh, not because it was a defect, but because my child has autism too and STEMs. So he
Yes.
would move his arms and, you know, would tell me, oh, he's on procedure. Is there anything, I don't know if there's anything out there where we could program what it is that, you know, how our child might have convulsed so that, you know, because I feel like he can wear the
Yeah.
watch.
It's such a great question. It's something that, like I said, my colleague Callie and I, we hear that a lot for kids who do STEM, or for kids who have other contributing factors that lead to body movements. Some kids with CP during sleep, they're very active sleepers, and so they're constantly setting things off. Unfortunately, my answer is not great because there's not a device that you can enter that information, which would be so great. I talked to a sweet mom, I think last year here, and she's like, every time I go to the grocery store, I have to tell my family if I get a wobbly shopping cart. Because she'd be pushing her shopping cart, and that would be alerting her whole team. And they're all calling her, are you okay? And she's like, yeah, I'm just at the store. So it's so hard because you don't want those false alarms. So that is something, like I said, we're always working on and keeping our ear to the ground, finding devices that are sort of trying to eliminate some of those. I know some of the devices are always working on, can the algorithm determine, is it a seizure, is it something else? But of course, you never want to miss a seizure. So they don't want to make it too good. If that answers your question, you know, because you don't want to eliminate something that could actually be seizure activity. But that's a great point and a really good thing that we can certainly bring up. These are the things that are so important. Companies come to us all the time and they'll say, what do they want? What is the patient looking for? So that's wonderful feedback. And we always remind young adults, don't brush your teeth with that hand. Make sure it's the other hand. And things like that. You don't want to alert mom and dad when you're just trying to brush your teeth. Yeah.
If a person passes away from your family, then you would have to pray for that person.
Absolutely. Yeah.
It's a part of your family that passed away.
Absolutely. Yeah, you're absolutely right. Yeah, thank you.
So he has a VNS. So you said that that keeps track of the seizure?
The VNS?
Yeah.
I don't know that the VNS does. And if I did say that, then I misspoke.
Okay.
Oh, you have your mag now.
Oh, so it's the one that goes in their brain that does. Oh,
Yeah.
okay. I got you.
Yeah.
Okay. Okay, got it.
And some of the wearables, like the watches and things, that'll keep a little diary and journal of the seizure activity and things. And then the SAMI would have the videos.
That's the buddy that he has in his chest. But yeah, they also have autism and they STEM
Yep.
a lot.
Yeah.
She's constantly
Yeah.
waiting.
That makes the wearables hard.
Yeah.
Yeah. And so we kind of say, if your child stims during the day a lot, but they're also having seizures at night, typically kiddos are not alone, right? There's always somebody around them. They might be at school, they might be with a nurse, mom, dad, whoever, caregiver. So during the day, we're able to watch them a little bit closer. But at night, that's when it can get really hard because, of course, caregivers and mom and dads, you have to be able to close your eyes to continue to take such good care of your kiddos. You have to rest. It's so important. So then we'll sort of talk to you about a nighttime monitor. And so utilizing a monitor at night is just a good step. You have nighttime seizures kind of covered when they're quiet and resting, and then during the day they're with somebody.
Right.
If your child has other movements or stimming like that, yeah. Night's a good place to start. Any other questions? Yeah.
Yes. Could you mention again or repeat what you were saying about heart rhythm or something that leads into death?
Can lead to SUDEP?
Uh-huh.
Yeah. So one of the contributing factors that's being studied is heart arrhythmias. So your heart has like a nice steady beat all day long. And so what can happen is during a seizure, again, your brain sort of stops and is resetting. And so that can lead to your heart having an arrhythmia that isn't conducive with life. And so it can be going too fast or really slow, or if that arrhythmia is prolonged, it can ultimately, your heart will just kind of shut off a little bit.
But first, the arrhythmia should be diagnosed by a cardiologist, or if...
Oh, you say like if she has an underlying heart condition potentially?
No, because we visit the cardiologist like twice, because I noticed that her heart rate when she just walks goes very fast, or she gets tired very easily. So I was saying, this is not normal. So I went to the cardiologist and she says there's nothing by fortune. But I'm still concerned about her heart rate. So first, it will be necessary to have a diagnosis of arrhythmia to be concerned, or?
It's not necessarily. You don't have to have a diagnosis of any cardiac abnormalities.
Yeah.
It could be caused due to a seizure, and then it would be one of the factors of SUDEP.
Yeah.
Any other questions? Well, I appreciate you guys so much. Thank you for listening. Thank you for learning about Danny, and hopefully we'll see you over at the table. Have a great rest of your time and enjoy.
Thank you.